our first speaker, and it really does give me great pleasure to introduce Professor Margaret Gyapong. Margaret is the Director of the Institute of Health Research at the University of Health and Allied Sciences in Ghana. She also happens to be the chair of our Scientific and Technical Advisory Committee at TDR and works very closely with us. So Margaret, please take the stage.
Thank you very much. And what an attendance. Thank you very much. Happy birthday, TDR. Happy birthday, MMV. And if you celebrated 50 or 25 years this year, happy birthday to you. In the 5 minutes that I have to speak, I'll be drawing on my own experiences and a document I saw recently published by the Global Fund on how to strengthen gender approaches within the malaria response. And I'm talking about gender-sensitive approaches to malaria interventions. It's no news that sex and gender impact health and well-being by exerting a combined influence on people's environmental and occupational risks, risk-taking behavior, access to and use of healthcare services, and abilities to make decisions about their own health. Any gender transformative program will seek to advance gender equality by addressing the underlying causes of gender inequality in health, including social norms and power imbalances between men, women, girls, boys, and gender-diverse communities. Antenatal care contacts remain an important platform for delivering intermittent preventive treatment for pregnant women, and can be an entry point for gender transformative malaria interventions, but we know that there are several barriers to seeking ANC, such as the long distances that women have to travel, the costs involved, and the work and family responsibilities. Such inequities, among other factors, have contributed to low IPT coverage in sub-Saharan Africa. And in 2021, only about a third of pregnant women received a 3-dose IPTP regimen. Hopefully, it would have increased a little more. Malaria programs are already working closely with reproductive, maternal, neonatal, and adolescent health programs. But where inequities in ANC services and reach exist, being intentional about specific transformative activities that focus on peer support and community engagement, amongst others, can address harmful gender norms and behavior that result in poor malaria-related health outcomes and significantly improve ANC access and uptake. The updated WHO recommendations on IPT recommend community-based delivery of IPT, or CIPTP, an innovative approach aimed at increasing coverage of IPT with SP. While not detracting from ANC, it complements ANC, giving all eligible pregnant women the opportunity to receive this treatment in the communities close to where they live, as well as at antenatal care facilities. In Ghana, many years ago, a colleague of mine, when we were working at the district level, decided to include volunteers in the distribution of SP because the coverage was that low. We involved male and female community distributors, and the achievements were tremendous. So I was really happy to note that the new documentation and guidelines is focusing on community IPT. Interventions that engage men and address harmful gender norms in ANC increase couple communication around family planning and ANC. It shifts power relations within couples and supports gender independence for women in decision-making. We've introduced what we call the pregnancy school in Ghana, and it's exciting to see men go with their wives and their partners to antenatal care and engaging in all the activities that go with reproductive and child health, and encouraging the woman to access her treatment. I think that in order not to pay lip service to gender-sensitive approaches to improving uptake of IPT and other interventions, all the social and other networks of pregnant women and girls need to be involved. Their partners, traditional healers, church leaders, and the significant others, and our healthcare workers. We assume they know what to do, and sometimes we leave them out of the matrix. If people are sensitized and uptake increases, stock outs should be a problem of the past to ensure that expectations are met. Expanding collection of disaggregated data on the grounds of sex and gender, as well as income, geographical locations, race, ethnicity, migration status, and other factors that are relevant and in local context is essential for increasing understanding of gender and intersecting barriers to malaria prevention and control. But those who manage and use the data need to be sensitized on the importance of looking at the issues from a gender lens in order to be able to use the indicators appropriately. At the end of the day, ladies and gentlemen, contextually sensitive behavior change communication that does not exclude the health workforce and a paradigm shift in the way programs are implemented is critical to ensuring a gender-sensitive approach to malaria interventions, particularly for IPTP. Thank you.